Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator in the NICU. And today we are going to honor and talk about and say the names of babies and children and miscarriages and babies we didn't meet and those that we did meet as we honor them during Pregnancy and Infant Loss Awareness Month. October is the time where we kind of pause and reflect on these babies that we've lost to miscarriage, stillbirth, SIDS, preterm birth, birth defects, infant mortalities, things in the NICU that have happened, such as neck or severe IVH, severe lung problems, cardiac anomalies, etc. But today, October 15th, is also Infant Loss Remembrance Day. So today is the day that we kind of pause and think about all the babies that we have lost in the various ways, whether you are a NICU nurse, a mom-baby nurse, a labor and delivery nurse, maybe you are in nursing school watching these videos, maybe you've helped a mom who you work in an OB clinic and you've helped a mom who's come in for a D&C after a miscarriage. All of these experiences are unique and they require us to know something about what they're experiencing and what they may expect in the next steps. But mostly, what I want to talk about today is how can we support our families through this and how can we support ourselves, the nurses taking care of these babies and these families each and every day. When we think about neonatal death is defined as a death of the baby in the first 28 days of life. It happens in about 3.58 of every 1,000 births. I know it's a pretty intense statistic, but we really lose babies in many ways. And when we think about the neonatal death, that could be of a preterm infant. That could be of a baby who has something like neck. It could be of a baby that goes home and has a SIDS event. There's a lot of different ways it kind of falls into that neonatal death. But we also have miscarriages, stillbirths, and we're going to dive into a little bit of each of those and then talk about support. So when we think about miscarriage, this is approximately 10 to 20% of pregnancies that end before the 20th week of pregnancy. That is the official diagnosis of miscarriage. You may have heard the term late miscarriage, where maybe it happens after the 12th week, or maybe it's more common in that first trimester. This usually happens because the fetus is not developing normally, or there could be something wrong with the placenta or the placental placement, bleeding in pregnancy, trauma, car accidents, other forms of accidents, things like that can lead to miscarriage. Every baby, right? When you lose a baby, it's never something that you're expected or thinking you're going to go through. I myself have had 2 miscarriages. One was considered a late miscarriage, as in the 12th week, and the other was part of my fertility story, my story to become a mom for the second time. And during that time, this was actually for the 3rd time, it was after my second baby. So first came my adoption, then came my first baby via pregnancy, and then I had a miscarriage during that time where we had done an embryo transfer and had changes in the blood work and never saw a heartbeat. The baby had implanted, but right around that 5th to 6th week is when we lost that baby. So every one of them was a different experience. Having a baby at a miscarriage at 12 weeks required a lot of intervention for my body to be done having the baby, a D&C as they call it. And so it was so emotionally different. And I will say that even this would have been, that pregnancy was 16 years ago. It was before we adopted our son, where we lost the baby in the 12th week. And even 16 years ago, we weren't really talking about this. Even when I was thinking about my fertility journey, it wasn't something we talked about as much as we do now, which I appreciate. If people want to share their stories, I think that's great for them and how we can build community around them and support them during this time. But it's really easy as a woman to blame yourself, to think you did something wrong, you couldn't carry the baby, you lost the baby. But at the end of the day, if miscarriages were preventable, we wouldn't have them. So they happen for whether the baby is unable to grow or something is going on with the mom. Now, that is a little bit different than a stillbirth. So, a stillbirth is defined as the death of a baby at or after 20 weeks of pregnancy, all the way up through full term. 1 in 160 pregnancies ends in stillbirth, and this affects over 24,000 families every year. This can happen from a lot of things. I don't know if you remember during our HIE lecture when we talked about true knots in the cord or nuchal cord or cord compression is one of the most common causes of stillbirth, and that the baby lays, has a knot in, the knot cord's wrapped around their neck. Something happens to the cord that compresses the blood flow through there, and the baby is no longer getting the oxygen and releasing the body of carbon dioxide through the placenta via the mom. So cord accidents, things that happen with the cord, a failed placenta, like the placenta outgrowing itself, whether it's past 40 weeks, something such as placenta previa, can increase your risk of stillbirth, and obviously placental insufficiency, abruption, uterine abruption, all of those could increase your risk for stillbirth. We don't always know why they happen either, which I feel like would probably be the most frustrating. Not that you want an answer, but the idea of like, okay, the baby had like all these knots in their cord when the baby came out. Yes, I can see why this could have happened. And also remember, a woman is still delivering these babies. You still deliver your stillborn baby. Some say they're born not breathing. So that's just something to really think about and how impactful that is and what the woman's body has to go through to deliver a baby who's born sleeping. So something to kind of think about. When we think about our preterm births, we know that 1 in 10 babies is born preterm. That complications from preterm birth are the leading cause of death for children under 5. Cause of death include respiratory distress syndrome, so never quite recovering from those lungs. When we talked about PIE or the need for using the oscillator or the jet, sometimes a whole area of a lung can be completely blocked off from being able to exchange gases, and which could lead to a neonatal death. Cardiac anomalies, the lungs being so sick that it puts pressure onto the heart, increases the heart's risk of failing. IVH, severe forms of IVH, neck infections, GBS sepsis, that's a big one. Our extremely premature infants have the highest risk of mortality, but of course anything that from the mom, multiple births, birth trauma. So one thing I wanted to point out that I have here in italics, despite advances in neonatal care, nearly 17% of extremely preterm infants do not survive. So we are doing great work, and we still have more work we can be doing. I think of these infants, every single one of them, whether they live for 1 day or 1 year, it is extremely traumatic for families and for nurses that have been taking care of them. So we're going to talk about how we can support them at the end. So birth defects are a leading cause of infant mortality, responsible for about 20% of infant deaths. So they are listed as leading an underlying cause of death for 70,000 babies between 2003 and 2017. That number hasn't changed much. I did go on the March of Dimes website, try to find the most up-to-date statistics. It still is very common, around that 20% here in 2024. I think it was like down to like 19.7. It hasn't changed that much. So this includes all those congenital anomalies, neural tube defects, and your trisomies, things that we've talked about in our previous lectures on congenital anomalies. So sometimes we work with palliative care teams. We're going to talk about the difference between palliative care and end-of-life care today, but really, how can we help support our families through these, whether the baby lives for 1 hour or a couple weeks, goes home on hospice, etc. Sudden infant death syndrome, or SIDS, is the sudden unexplained death of an infant under 1 year old. It is a leading cause of death for infants 1 month to 1 year, and most commonly occurs between 2 and 4 months postpartum, when the baby is 2 to 4 months old. Safe sleep practices, right? We could talk about this till we're blue in the face. And I was commenting on someone's Instagram recently who was talking about safe sleep practices. There's some new recommendations from the AAP. There's even recommendations for NICUs and when we should be doing head of the bed flat and removing positioning devices. I highly recommend you go check it out, because what we are modeling in the NICU is what parents think is safe at home and what we get the babies used to. We get the babies used to head of the bed elevated for their whole NICU stay, and we put it down 2 days before they go home. We can see why that can be tricky for families. But We want to place the babies on their back. No smoking in the home. Smoking in the home is the number one risk factor for a baby having SIDS. So no smoking. Sleeping in the same room is a good thing. We want them to sleep in the same room, but not the same bed, have their own safe sleep space, but that has decreased the rates of SIDS in recent years. Breastfeeding, avoiding overheating and overdressing. A big part of this, the idea of like not having things in the bed and no bumpers, is this overheating, that when the baby gets too close to the bumpers, they get really hot and warm, and that leads them to be tachypnic, and they blow off all their CO2, and then they lose their drive to breathe. These are just some of the many, many resources out there. You can go on any great reputable AAP, March of Dimes. There's great sites out there that talk about how to reduce your risk for SIDS. I think it's really important to think about those things. That should be a big part of your discharge teaching as a NICU nurse. What can we do to help these parents understand and to safely practice sleep at home? Let's talk a little bit about this idea of palliative care versus end-of-life care. Palliative care, I remember the first time I heard that in the NICU, and I thought to myself, why are we talking about palliative care? This baby is like on a ventilator and we're still helping them and we're doing all these great things. But really, palliative care, when you think about timing, can happen any point after a diagnosis is given, even if the baby continues to receive life-saving treatments. And that's different than end-of-life care that really begins when death is imminent. And maybe the baby's heart rate is going below 60 or has been, or we've been doing a code, or the baby was a no code and we know that they are going to pass soon. That's what end-of-life care is. Palliative care, the goal of palliative care is to improve the quality of life regardless of the prognosis and how much time is left. So we might be doing palliative care for a few weeks as we prepare a baby towards the end of their life and their families. Maybe we're setting that up through hospice care. Palliative care really can support the infant and the family as they are going through this. Palliative care, their scope is that they do symptom management alongside with curative efforts. So you can have a baby with a feeding tube or a PICC line who is receiving palliative care. Those things can be congruent. They can be happening at the same time. Two things can be true. You know how much I love to say that. Whereas end-of-life care typically involves only the comfort measures as active treatments are withdrawn. So I want you to think about palliative care in the NICU is about supporting the baby and the family through a serious illness, while end-of-life care is about comfort and dignity. Both of those things are so important. Palliative care can lead to end-of-life care, and we could end up doing both of those things. But I really want you to think about palliative care as such a good thing, in the way that they help our parents transition through the end of their baby's life is life-changing. And I think we don't talk about palliative care because in a way it kind of makes us uncomfortable to think that maybe are we saying that we're giving up? We're not giving up. We're offering another resource to a family who's going through something. And that's just another part of supporting our families through loss. We get stuck sometimes in this idea of, I don't want to say anything, I don't want to say the wrong thing, I don't want them to think that I think I'm giving up or that they gave up too early. Really, some of these things that we can say, I'm going to tell you some of the ones we can say, some things we shouldn't say, some things I've said and regretted. We can say things like, I'm here for you. What can I do to be helpful? Do you have the resources you need? Tell me about your baby. Tell me about your family. Another thing that happens in the NICU is that we will have a baby admitted who's lost a sibling. Asking the parents about their family. What makes up your family? Tell me about your family. Tell me about your child. Silence is okay. Maybe the parents don't want us to talk. You can say, I'm just going to sit right here, and when you need something or you want to talk, I'm going to be here ready to help you. There's so much power in that. This idea that we can be together without having to solve a solution or having you, need me to guide you through something. I remember being with a family who had an unexpected hydroptic baby. Their baby was hydroptic. She never did great. She lived 4 days. We knew she was going to die. There was nothing that we could do outside of what we had already done. The parents were, they didn't want to hold her. She was very unstable, and so they were kind of holding in the bed, and the parents looked over at me at one point and they said, I don't know how you do this. I don't know how you do this day in and day out. And I just thought to myself, and I said to her, What a privilege it is to be with you during this time. This is a window of opportunity to be with someone in their most vulnerable state, helping them through something that they never thought that they were going to go through. And I just stayed with them and listened to them and supported them and really wanted to do what they wanted and to make sure that we offered them the things that we had. Things that we don't want to be saying, and things I have caught myself saying, are things like, everything happens for a reason. You can always have another baby. I have said this, and I will never forget the look on the woman's face, which was, oh my gosh, you don't even look like you were pregnant. And it was like, yeah, that's because I had a 24-weeker and they died. Like, my body never got to experience pregnancy. And I was like, oh my gosh. Saying things, at least it happened early in your pregnancy, for people with miscarriage, that doesn't make it okay. I lost, as I mentioned, a baby at 12 weeks, and a baby and I had been together for 12 weeks. It was kind of an unexpected pregnancy. We had been married for 5 years. We weren't actively trying or doing anything like that. And it was still so detrimental. And a lot of it happened at home, which was also really stressful. So to say like, oh, it happened early, you're so lucky, that doesn't feel great either. So I want you to pause. You can screenshot this, kind of write some of these things down of phrases to get in your head and those to avoid. There's so many ways that we can honor the infant during this time, and it's getting better and better every day. We're doing such a great job with this, and there's been so many advances. I encourage you to comment on here or send me a message of what you're doing to honor your infants. These are just a few things. I think the most important thing is to ask the family what they want, and they may not know. And when a family doesn't know what they want to do, I tend to say, why don't we do everything? I'll put it in this box and you can come pick it up when you're ready. Or I'll put it in this box and I'll send it home with your mom. And when you're ready to look at it, it will be there for you. But we only have one chance to do it. So let's go ahead and make a memory box with ID blanket. Let's cut a lock of hair. Let's get their handprints and footprints on molds, on clay, in a book from the baby to the parents. If we can, before the baby dies, can we record their heartbeat and put it in a heartbeat bear or a stuffed animal for them to have comfort? Some people have recorded that on their cell phone so that they always have their baby's heartbeat with them. I think the worst thing we can do is not offer anything, or to really do something and push the families outside of their comfort zone. We also shouldn't do things without their permission. So if they ask us not to do it, we shouldn't do it and assume that they would want to come pick it up. Just some things to think about. Having a specialized team or trained nurses on your unit that help with heartbreak care, end of life care is also really great. There's also a certification for this, and there have been conferences about how nurses can support families and their babies through end-of-life care. Highly recommend them. If this is something that you're interested in, there are so many great resources out there. There are organizations that will donate dresses made from old wedding dresses for an infant to be in, clothes, books for siblings, things for parents, better Kleenex, even if that's something that you need on your unit so you don't have the hospital terrible Kleenex. There are a lot of great things out there, and I highly recommend using all of them. So how can we care for ourselves? The number one thing that we as NICU nurses need to do after a loss, or labor and delivery nurse, or mom baby nurse, is to have a debrief. It doesn't have to be in the moment. In the moment is going to be great, especially if you've had a sudden death, maybe a code, or you've had a death of an infant that's been in your unit for a long time. But having a debrief, a few days later, or a week later, or a once a month type of situation, opportunities to discuss difficult cases with your team is going to allow you to process in a safe environment where everybody's experiencing the same thing. I believe I'm going to be putting resources on my Instagram page, so make sure you're following me there throughout this week of things that you can use as resources. The feelings wheel is one of my favorite, because we'll say like, how do you feel? Sad, mad, glad? No, like sometimes you feel sad because you're disappointed, or you're wondering, could I have done more? What more could I have done? Should I have seen this sooner? Should I have escalated more? You have regret. Regret is this feeling that's living inside of you of, what else could I have done? Should I have said something else to the parents? What else could I have helped the parents with? So talking these things through with a trusted group of coworkers is going to be key. Asking your unit if they or your facility offer any therapy services, counseling service, group counseling, individual counseling to help support you through that. Taking time for rest, reflection, emotional well-being, journaling, exercising, yoga, meditation, doing crafts. It's tricky, right? I've been a NICU nurse for over 20 years, almost 21 years. My husband still doesn't quite get it, and he can't. Nobody can get this. This is something that we're doing. There's not something to get. So it also can become a place where we're commiserating with each other, and we kind of get stuck in this rut of like, oh, we should have done this, we should have done that, instead of pausing, talking about what we really did well, what went well, what were the things that went well. Are there opportunities to improve on our processes, but knowing that nothing that you as an individual did is going to change the outcome of what happened. And I empower you to remember that and to debrief so that you can have that feeling. But no matter what, self-care, which is such a buzzword right now, and sometimes it drives me crazy, but finding what helps you after these things happen. Just almost 2 years ago, I had one of the worst Decembers, right? We had these two babies it was 3 babies in one day, 2 that I was a big part of. And one of them was an older baby, a term baby, came to us suddenly, kind of looked like HIE, and the baby was born just before midnight and died at 9 a.m. The other one was a small baby who had been with us for about 7 weeks and had overwhelming sepsis. And both of those babies, their bodies were different, their families were different, their experience was different, and both of them hit me like so hard. And it was December, and there was just so much going on, and it took me longer to process those than I processed others. So I implore you to continue to remember these as opportunities to pause and say, is there something else I need to be doing to making sure I'm taking care of myself? Maybe what I did before with yoga and meditation worked, but it's not working this time. So maybe this time I need counseling, or I need a journal. What can I do that's a little bit different? So we know that miscarriage, stillbirth, SIDS, preterm birth, birth defects, and end 1 in 4 pregnancies. Lots of grief, lots of comfort needed. Supporting nurses is so important, supporting each other, reaching out to someone that you know just went through a difficult time at work is going to be so helpful. Debriefing sessions, peer support, self-care is going to process us through this, and continuing to talk about it and knowing that it's not just something that should happen. It's something that we need to pause and reflect on, that it may be a part of us that knows that this is part of our job, but that doesn't make it easy, and it doesn't make it okay. And it's okay to not be okay, and to pause and say, let's reflect on this. Let's honor the baby whose life we just were a part of. And by doing so, we can reflect and see how we can improve for the future. So thank you for joining me for this Teach Me Tuesday. If you have experienced a pregnancy or infant loss, my heart is with you. I hope today, on this day of remembrance, you find comfort, and let us know your baby's name and their story so that we can speak it with you. Have a great Tuesday.